Thank you so much. We move on to the next session and the last session. Challenging cases by invited faculties. As chairperson, I would like to invite on the dais Dr. Shourang Chatterjee sir once again and Dr. Pronita Nondi ma'am, please. Welcome, sir. Our first speaker is Dr. Madhu Shukla ma'am.
So I'm going to present this is a case which is very close to my heart, and I learned a lot of lessons from this. So I thought we will present this case to you. This is a case, I have kept a topic, is it acute coronary syndrome in a patient with DDR pacing? Cardiac troponin is a sensitive and specific marker of myocardial injury and is useful in diagnosing and assessing prognosis in acute coronary syndromes. However, it is released in a variety of non-acute coronary syndromes, conditions like heart failure, atrial fibrillation, SVT, sepsis, pulmonary embolism, myocarditis and CVA, etc. Aim of this presentation is hypertroponinemia and raised BNP secondary to chronic RV pacing are uncommonly reported. These biomarkers can occasionally confuse us. RV apical pacing causes LVBV type of activation pattern, resulting in delayed and asynchronous LV electrical activation and mechanical contraction. Reduced LV systolic function, decreased myocardial work, depressed pump function, and a shift in the LV pressure volume relationship with lower end systolic pressure and a greater end systolic volume. So this is a lady, 64 years old female, had CHB since 2006. She was on DDR pacing in 2006. PGR was done in 2016 and came again on March 22, 2023. She was an elective patient, but night before she was scheduled for the admission, she presented with chest pain and doctors in emergency admitted in CCU and resident gave a phone, patient has come with the chest pain and troponin cardiac triage is positive, so they loaded this lady. She had acute chest pain on the night of 21st March and she was admitted. Troponin was 0.27 and BNP 578. ECG showed ASVP and BP was 140/94 and pulse rate was 68. This was the ECG of this lady. I came in the morning and when I was assessing, I inquired with the lady. She gave me exactly pain which was suggested of acute coronary syndrome. Then I did this echo and you can clearly see the anterior septum is hypokinetic. And this is the 4-chamber view, bedside echo. Only basal segments are having good contractions. The apical segments are not well contracting. So is it acute coronary syndrome in LAD territory, Takotsubo cardiomyopathy, or just pacing-induced segmental wall motion abnormality and troponin release? These are the questions which appeared in my mind. And when the strain was seen, there was dyskinesis of apical segments, you can see clearly. And this was the transmitral flow showing diastolic filling period 250 milliseconds, 27% of the cardiac cycle. On the right side, here left side, you can see the tissue velocities. On the medial side, E and A fused. And this is on the lateral side, however, the E is 7 centimeter per second. And this is the normal RV function. So ACS remained possibility. Segmental wall motion in apical, mid-septal and mid-anterior and mid-lateral segment with raised troponin and chest pain. GLS was -13. Markedly short diastolic filling period due to marked synchrony. Normal RV function, elevated troponin and BNP. This was the summary of this patient. Now sir came. He comes later to me. I requested him to do an angiogram. He said, no, it is just because of pacing. But I thought she is giving a history of chest pain, and if we miss something, so I requested her to do the angiogram. So we decided to perform coronary angiogram just before putting the pacemaker, changing the pacemaker. So this was the angiogram. You can see right dominant circulation, very short LMCA, very short LMCA, you will see here, near separate origin of LAD and LCX. You can see more pictures. This is still one. And then as it was normal, so we thought we will do myocardial contrast imaging also so that we can rule out Minoka. You can see the pictures. The perfusion is pretty well. There is normal perfusion, but apical dyskinesis is there. You can see more picture. And 14 days later, she came in the OPD when we were removing the stitches, and we again performed the echo, and you can see the dyskinesis remains as such. And heart rate was 104 beats per minute, and strain was minus 14.6, and apical dyskinesis persisted. You can see these pictures. So our conclusion is RV apical pacing induces segmental wall motion abnormality, hypertroponemia, and subclinical heart failure. Constant RV pacing may produce myocardial injury and LV dysfunction with segmental wall motion abnormality. And this is the study to show BNP levels are markedly elevated initially and then fall somewhat but remain high, about 3 times normal in such patients. And 64% of the patients on RV pacing have segmental wall motion abnormality, mostly apical. So the results are LV wall motion abnormality was observed in 64% of the subjects and was more pronounced in apical segments than in other segments. At 2 years later, after pacemaker implantation, BNP levels were significantly higher in group with RV pacing, which use more than 50%. And in the subjects which use RV pacing, I think there's something wrong. Significantly higher, okay. More than 50% had higher LV and diastolic volume and lower ejection fraction at 3 years after pacemaker implantation. Conclusion, long-term RV apical pacing elicits apical wall motion abnormalities that could in part contribute to LV contractile dysfunction and cause pacing-induced cardiomyopathy. This is another thing. These are various studies which I think I would like to end here only. That's all. So this case gave me insight because I'm working with Professor Mohan, so I am always under that much stress that if we evaluate a case, there we don't have to be wrong, because if I do something wrong, that is going with his name. So I requested him to do the angiogram, though he was laughing, and he said, Madhu, this is only because of apical pacing, nothing else. But patient had a typical chest pain. So I requested him, and I learned a lesson. He made me learn so many things to study all this. So I thought I will present what I experienced in my life.
Would you like to repeat the echo after 6 months?
Yes, she will come in follow-up.
Because I want to be sure that it is not Takotsubo also.
Okay. In next meeting, we will present that.
Any questions from the house? We go to the next speaker.
Professor
No problem. Thank you, Deepu, for giving me this chance to be in this meeting. Great meeting, great learning, and humbled and honored to be here. Uh, we wish to have a long association with you with this. Yes, of course. The difficulty with me is that I am able to remember only your name. You know, I am getting old and I am getting some Alzheimer. So the difficulty is I, I have this. So what I'll do is I will present a quick case, and thank you West Bengal Echo Academy for inviting me to this meeting. Great meeting, and as I said, great learning, humbled, honored, and we will keep this association. We will try to come better with better cases, better learning in future, and we'll learn from each other more. So let me quickly show a case, or maybe two cases. The title is Two Tales with Similar Beginning or Different Endings. Dr. Madhu did present yesterday a case showing that the purpose of primary PCI is to salvage the myocardium and of course to decrease the size of infarct as less as possible compared to area at risk. If the area at risk is large and the infarct size is also large, then we don't achieve anything by PCI. But on the other hand, final infarct size small, blue color, we have done a great job. This is exactly what we are aiming at. So here is a story of 56-year diabetic male who had a PCI, prior PCI and LAD in 2011. He came with acute chest pain on May 18, 2022, infralateral myocardial and of course, I quickly finished PTCA within actually 1 hour of him having arrived in the hospital. Although his chest pain had occurred after dinner, so it was surprising what time he had dinner and then what he presented. He actually had he presented when the chest pain became severe at 4 o'clock. Nevertheless, this is the electrocardiogram of this individual before PCI, showing you typical infralateral myocardial infarction or posterior myocardial infarction, large R wave in V2, V3 with ST segment depression, and this is the ECG post PCI on the right side. So everything settled down except telltale evidence of posterior myocardial infarction, the R over S in V2 being still more than 1. So far, so good. So this was a patient who had, I said, angioplasty in 2011, and in LAD, the LAD is occluded distally, but at this time, patient has come with LCX disease, and you can see occluded LCX. I decided to open the occluded occluded LCX, opened the occluded LCX. This is the great result, finally. This is finally the great result, and satisfied with the overall result. Patient was doing well. Next day we did a contrast to show what have we achieved, and we have a small subendocardial infralateral area of non-perfusion, small one. You can see the arrow. So we have done a great job. Most of the myocardium is salvaged, only a small portion. This is expected because patient probably was having stuttering infarct. Some necrosis had to happen before we intervened, but we intervened well in time, and still, if you see carefully, it's only a small sliver. If you go around 360 degree, this probably forms less than 20 degree overall, or maybe less than 30 degree. So pretty much set. And this also is subendocardial. If you see the bigger arrow, the subepicardial area is well supplied, is well perfused. So we are very happy with that. Contrast after 6 hours, of course, showing you all other segments are contracting pretty well except basal inferior. Contrasted with case 2, 58-year female, same age actually, average built up with previously asymptomatic, known hypertensive on telmisartan 80 milligram a day, and mother of several doctors and mother-in-law of several doctors. So she reaches the emergency at 7:30 a.m. Sorry, it's not p.m. It is 7:30 a.m. and in ER she reaches in 10 minutes. They were living very close to the hospital. And so a lot of hue and cry, and I had to actually, so I live 27 kilometers from the hospital. So I had to drive at breakneck speed to reach there because the doctors were shouting. So I reached there, but I was into the L6 wire. I was into the L6 with guide wire at 8:50 a.m., which was as quickly as I could reach, and the PCI was finished at 9. But what happened was, this is the electrocardiogram of the patient. Again, the infralateral myocardial infarction, classic case, nothing to discuss. Right coronary artery is normal, and occluded circumflex artery. right? So this was the artery which I opened. This is occluded artery, and this is of course the good result. All OMs are patent, very good result. No staining, no good tissue perfusion, happy. But patient developed severe hypotension after balloon dilatation. But I still went on and completed the PCI with his eye stent at 16 atmosphere for 60 seconds. She continued to have discomfort. This is the ECG post-PCI, half an hour after completing the PCI. Still ST segment depression significant in V1 to V5, V6. But the ST segment elevation L2, 3 was settled. Immediate echo after PCI while the BP is less than 80 millimeter of mercury. You see the inferior vena cava dilated on right side. Patient obviously is in acute heart failure. I have done angioplasty within 90 minutes of development of chest pain. Great result according to me, but patient has, so what do we find? LA is somewhat dilated, but LV function is pretty good. If you look at the left ventricle, that's contracting vigorously. So what is wrong? This is state of acute diastolic heart failure. Why did it occur? We'll talk about that. So the patient has developed severe tricuspid regurgitation. MR is mild. Problem is LA is big and you have a markedly elevated PS systolic pressure and severe TR. Okay? And of course the filling pressures are elevated. So what did we do? What was wrong actually? When we do this echo and found the entire area supplied by circumflex artery in this case is markedly thickened. You see marked regional thickening, and I told you yesterday that this represents myocardial edema as a result of reperfusion injury. So our patient had severe reperfusion injury, acute diastolic heart failure, acute decompensating heart failure, and severe TR. And this is known phenomenon, and we have seen good number of such examples. You would say, okay, you have opened the circumflex so well, you have shown everything, and now you are showing the regional thickening. What is its significance? So this is the significance of the regional artery thickening. You see large sliver, nearly 180 degree, where there is no perfusion. 180 degree from 3 o'clock till 9 o'clock position, where you don't see perfusion, at least in subendocardial area. That is what is reperfusion injury, and it corresponds with marked thickening of the wall. Thickening is all because of the myocardial edema and reperfusion injury. So you can again look at in parallel long axis view, look at the marked thickening. That, don't confuse that. That is a muscle in the right ventricle. The septum is quite all right. And of course, look at the septum, look at the infralateral wall, look at the thickening. And this is well perfused septum, absolutely no perfusion. Opened the artery within 90 minutes using all precautions, everything which should have been done, but there is no perfusion and marked thickening. You want to see it better? Of course, this is going on. You can see the perfusion defect. Overall, LV function is pretty good actually at the moment. The whole problem is markedly stiff left ventricle, raising the filling pressure, raising the pulmonary artery pressure. So some patients following successful PCI in AMI show marked regional wall thickening and regional echolucency like intramural tumor. This change is a combination of edema, inflammation, and hemorrhage. There are immediate consequences of this change in the form of pap muscle dysfunction, a marked increase in stiffness and acute heart failure, like our case, echo can pick up this change better, although CMR can characterize it better. So just to show you all those pictures, but the icing on the cake is, we did a myocardial contrast echo after 3 days. So that's the baseline, and this is after 3 days. Now the perfusion defect is transmural. Whatever capillaries were present and bringing blood to subepicardial region, because of the edema, have collapsed. They have been collapsed by hydrostatic pressure. So now you look at the thickening on day 3, look at the marked thickening of the wall. Compare it with the septum, compare it with the anterior wall, and look at the thickening, tumor-like thickening of the infralateral wall. And of course, it is also involving the inferior wall, the lateral wall where there is no perfusion. And so compare day 0 from day 3. Now you'll realize what I'm talking. Day 0 was this perfusion defect. Day 3 is this big transmural perfusion defect. Whatever capillaries were bringing blood to this, because of the myocardial edema, got closed and got choked from outside. That is because of the compression of the capillaries. And this is what these, although the ECG finally settled down, but the damage is done. To summarize, ladies and gentlemen, acute reperfusion injury following primary PCI LCX with ischemic time of 90 minutes were done in this case. Patient presented with acute shock, severe PH, severe right heart failure. She stabilized with oxygen, small fluids, and noradrenaline and diuretics. Her BP was low till day 4 with low oxygen saturation. So injury produced by rapid reperfusion, which is time independent, technique independent, operator skill independent, is unpredictable and prognostically sinister. This is what happens. Dr. Madhu showed you a picture. This is what happens actually in these individuals with reperfusion injury, ischemia reperfusion injury. The gaps in the basement membrane open up, plasma, red blood cells, all other cells come, and when these the neutrophils come up, inflammatory cascade starts, and with all kind of inflammatory substances. Thickening correlates with myocardial necrosis. Segmental necrosis, segmental thickening on y-axis, segmental necrosis on x-axis. More is the thickening, more is the chances that all area will die, will be dead completely. And why? Because myocardial edema increases the hydrostatic pressure of interstitium, capillary compression, which causes myonecrosis, and mural hemorrhage also. And of course, you have stiff heart, reduced compliance, elevated filling pressure. Water logging is too bad for the heart, remember. But at the end, we need to remember that some degree of segmental wall motion, some degree of segmental wall thickening occurs in 70 to 80% patients. This is because some reperfusion is occurring, some damage will occur. It is 5% of those patients where I showed you a case where you have a marked segmental myocardial wall thickness, which you can pick up an echo. These are the patients who do extremely poorly over long period of time. Thank you very much. Sorry I had to rush through these cases. We have a flight to catch. Program got slightly delayed, but nevertheless, thank you West Bengal Academy of Echocardiography. Thank you organizers, and a great meeting, great learning experience. Thanks a lot.
Runs and runs of patients, we are catching such patients, and we have presented 4, 5, 6, 10 cases like this. So this is the basic cause, and we don't find at that, when you don't see like this, you don't see. But when you start seeing things, you can better analyze.
One question here from the,
Yes.
can we predict the development of this injury after?
No, we can't. I said it's unpredictable. It is prognostically sinister, independent of time, technical skill, and operator's experience. It happens all the
Wall
time.
thickness doesn't matter.
No, it doesn't matter at all.
Okay.
And we have actually hundreds of such examples, not small, hundreds of such examples timed, and we keep presenting. The case Dr. Madhu presented, I think the chairpersons had a little difficulty in understand the whole issue. First you see a lot of myocardial edema, and then you see myonecrosis coming up.
Dr. Anindya, please.
So regional wall thickening actually, which is out of proportion, is a clear indication that myocardial reperfusion injury has taken place, and this whole area will die. I showed you a slide by TTC myonecrosis and regional wall thickening. Greater is the delta wall thickening, greater is the myonecrosis.
Sir, one question. In this time, can you do even the myocardial perfusion imaging by the contrast?
Yes.
To see that there is a whole capillary blood flow has been damaged or this is partially damaged? Can you do it?
Yeah, absolutely we can do it.
That can be done. So that you can predict a little bit. If it is not totally the capillary collapse, then is the chance of getting the recovery is absolutely.
So we do it much more regularly. Hopefully next time we'll show you more cases. We could have a whole session on myocardial contrast echo next meeting. Thank you very much. Again, sorry I have to rush.
To continue with the session, Dr. Anirudh, please.
Yeah, that's a very interesting case. I'll show you. A patient presented with a history of exercise intolerance, chest pain on exertion and syncope. The physical examination was remarkable for a grade 4 by 6 harsh ejection systolic murmur, which was loudest over the base of the heart and radiated to the neck. There was no diastolic murmurs, and ejection click was not present. An electrocardiogram, the chest X-ray is normal. This is the first clip. Is anybody in the podium? Can you tell me what is the actual pathology you are seeing? Is anybody in the hall? The purpose of presenting in this case is that to recognize that what I am showing you. Okay, if it is not, then we can do the, I'll show you the very other pictures. No, sir, this is not orbital. See all the pictures, sir. Aortic valve is absolutely normal. Look at the mitral valve, sir. Look at the mitral valve. Which one? No, sir, this is not also a subaortic membrane. Sir, if I get her. See, this is over the anterior liblet of the mitral valve totally. And it is extending up to the LV outflow tract. Yeah, there is a membrane. But this is going under the totally tract. And it is sitting on the absolutely on the anterior mitral valve. Yes, it's the accessory mitral valve tissue. And there is, you can see, there is no obstruction with the level in this there. There is only aortic regurgitation. And of course, there is a LV outflow tract obstruction. There is a severe, almost not severe, but it is going up to the 4 meters, almost severe. But in addition to that, look at the RV. There is Epstein anomaly. See the septal leaflet. See, septal leaflet is more apical and the long anterior leaflet giving to the coaptation failure. And you can see the point of coaptation along with the tear. Of course, there is a very little mitral and grade 1 mitral regurgitation, and you can see this accessory mitral valve tissue absolutely going into the LV outflow tract. And these accessory mitral now it is a very clear, this whole of the accessory mitral valve tissue and extending up to the LV outflow tract, leading to the LV outflow obstruction, and there is of course some amount of aortic regurgitation because of the and it is reaching up to the almost 4 to 4.5 meter with the severe aortic obstruction. And of course, mild elevation of the pulmonary artery pressure is also there, leading up to 3 meter. So there's a zoom view, you can see very clearly the accessory mitral valve tissue. Yeah, going to the big. In spite of tear, but this is a low pressure tear. You know these in Epstein? Yeah, LA pressure is high. So basically this is an accessory mitral valve tissue with Epstein anomaly. So I have given a little glimpse about what is accessory mitral valve tissue. This is a congenital malformation of the mitral valve, such as insertion within the left ventricular outflow tract, prolapse of the redundant chordae or leaflet, and accessory mitral valve tissue, we call it ACMVT, and very rare cause of sometimes subaortic obstruction. So accessory mitral valve tissue is a rare congenital malformation. Age, it can happen from newborns to 77 years old. Severe LVOT is present in most cases. Patient with ACMVT causing LVOT may undergo safe mass excision with acceptable postoperative mortality and morbidity. The removal of the ACMVT should in no way compromise the mitral valve function, and its excision should be made subject to careful evaluation of the surrounding structure. Basically, there are two types on the reported intraoperative finding. There is a type 1 is the fixed type, that is A is nodular, B is the membranous, and type 2 is the mobile type, A is pedunculated, B is leaflet type. So type A or type B or type 2A or 2B. This is type 2B is divided into rudimentary chordae and the developed chordae. only case reported in the literature with the accessory mitral valve tissue with the Epstein is this. There's no other case has been reported in the literature. A 26-year-old man with a history of effort-induced syncope attack was found to have Epstein anomaly. A cardiac catheterization revealed a pressure gradient of 77 mm between the left ventricular output tract, which was caused by mitral accessory tissue. Accessory was resected, and the aortic valve was replaced, and the Epstein anomaly is corrected. The degree of mitral degradation is seen to increase the following surgery. This is the first reported case of an accessory mitral valve complicated with Epstein anomaly, and this is probably the second one. And another case, I am giving proxy for Dr. Samir Srivastavan. Subra has requested this particular case. So I'll tell you a story of a vanishing vegetation. Anyway, this picture is taken in a river valley in the Yangtze River in the Guilin, China. I think, and this is a story of 86-year-old diabetic man presented with the generalized weakness with fever and the respiratory distress for the last 1 month. Remember, the 86-year-old. He was put on a permanent pacemaker 2 years back and with pacemaker-dependent rhythm. Baseline investigation revealed total leukocyte count of 10,000, 70% neutrophil and the raised CRP. Treated with the different antibiotics without any response. Soft systolic murmurs in the precordium, blood culture positive for Candida tropicalis. So this is the first picture in the transthoracic window. We can see a little more, there is a grade 1 tear. Look at the pulmonary artery pressure is near about mild elevation, 2.8. But look at this, there is some vegetation looking in the pacing leads. I'll go you the different pictures. Then you'll be able to identify. This is the second one. Then go to the, you can see very clearly the vegetations. Also more. See, there are vegetations in the pacing leads. Also maybe some vegetation in the tricuspid valve also, probably. And this is a amount, that is a large vegetation you can see in the still pictures. And in the zoom view, it is very clearly seen, you can see the vegetation totally sitting on the pacing leads. So it's a large fungal endocarditis involving the pacemaker lead. We did the TE of this patient. Even in the TE, you can see the pacing wear, and here you can see the clearly the vegetation. More picture, you can see the large vegetation, very large vegetation sitting in the pacing leads. More pictures, very large, like a grape-like vegetations you can see in the pacing leads, attached to the pacing leads. Another more in the TE. Another from another angle, other angles. So there is no doubt about it. Left atrial appendage is clear. Aortic valve is normal. So what we summarize, 86-year-old man, fever with severe general disability, pacemaker dependent rhythm, large fungal vegetation in the pacemaker lead, culture sensitivity is Candida tropicalis, sensitive to flucytosine, amphotericin B, fluconazole, voriconazole and capsofungin. Patient, his family refused any surgery. What to do? The optimal management of the pacemaker endocarditis requires immediate surgical removal by the entire pacing system accompanied by administration of antibiotics or antifungal. High rate of uncontrolled infection or relapse among patients with the septicemia in relation to the PM material infection confirms the need for immediate removal of the entire pacing system. What we did, because the patient refused surgery and is a pacemaker dependent reading, we give a trial of capsofungin. An initial dose of 70 mg by intravenous infusion is given, followed by 50 mg intravenous daily for 10 days. An infusion to take approximately 1 hour should be given very slowly. Then followed by intravenous fluconazole for 15 days and subsequently put on oral fluconazole 200 mg BID for 2 months. Total duration of the treatment was 8 weeks. Regular assessment of the hepatic and other parameters were done for the long-term treatment. And now, after 2 months, you see the transthoracic pictures. We could not find anything in the tricuspid valve or in the pacing leads. More pictures, zoom pictures. There is nothing absolutely clear toward the RA, RV, and everywhere. Then mild tear, as usual, because of the pacing leads. We did the transesophageal again, and you can see the pacing lead is absolutely clear. This is absolutely clear. This pacing lead is absolutely clear. We could not demonstrate any vegetation anywhere, even by the transesophageal echocardiography. So nothing was there. This is the lead one. You can see very clearly. This is absolutely clear. Why did it? The ESMID 2010 guidelines and scientific statement by the American Heart Association published in 2015 recommended surgical explantation of the infected device along with the liposomal amphotericin B or capsofungin, either singly or in combination with the fluocytosine followed by suppression therapy with fluconazole. In cases where surgery was contraindicated or refused due to presence of comorbidities, capsofungin and the liposomal amphotericin B were used successfully, with or with subsequent lifelong suppressive therapy with fluconazole. Final result, what we got, no vegetation detected even with the TE, full response only with the antifungal agent. The patient was followed up for the 1 year with echocardiography, no recurrence, no significant side effect, extremely rare even in literature, even rare to have complete eradication of the vegetation by antifungal treatment alone, particularly who have a limited life expectancy or have refused device removal. It is already published. Thank you.
Any questions? Dr. Shantanu Sengupta, please.
So thank you so much. I think I'm the last one between the prizes. Oh, he's coming. Okay. So I'm just going to take quick 5 to 7 minutes. It's a very simple case, nothing great about it. Okay, so this was a 55-year-old man who got positive with COVID since 7 days, had an MVR 4 years back. This time came to hospital because of COVID, because he started feeling dyspnea and immediately asked for a CT scan. They wanted the CT score. And on admission, he was febrile, he was diabetic, sugars of 210, hypotensive. The CT score was only 2/25, so that didn't explain his breathlessness. Counts were higher, the procalcitonin was high, 1.8 creatinine, the SGOT-SGPT was elevated, INR was 3.6, NT-proBNP was higher. So we got an echo. It was difficult to get an echo during the COVID time, but so this is the echo. So if you can see, there is a prosthetic mitral valve, but we start seeing something at the top. So I don't know why the laser is not working. Okay, so let me go back. So this patient had evidence of there was an evidence of pericardial fluid which was around and which was the problem which was causing him breathlessness. So always the COVID doesn't cause any problem in terms of the lung pathology. So this patient had evidence of pericardial effusion, and that's the reason of symptomatic. The main thing was there was evidence of LV collapse, and this was the, so it is asking Taj to join me, I don't know why. Okay. So this was the respiratory variation both at the MV and the tricuspid flow. There was evidence of collapse, both RV collapse and LV collapse, and we could diagnose LV diastolic collapse, need of immediate, yeah. So what we did, this was the options. Of course, there was no other point, but in this setting of cardiac tamponade, a turbid hemorrhagic fluid was aspirated, and we sent the sample, and because he was diabetic, interestingly, there was evidence of Staph aureus grown. So this was myopericarditis, and there are some reports which came out that COVID could also come with myopericarditis with tamponade in the absence of respiratory symptoms. Also, pleural effusion, pericardial effusion, everything has been reported. I'm sure you guys must have also seen the thing. So this is an important thing, that it is not only the lung pathology, but also involvement of heart in a pericardial, with pericardial tamponade can have. So this is the first case, but I want you to take this opportunity to give you something very interesting, something insight. I think this is not an echo thing, but this is what has come up recently. This is because we all are cardiologists and having, so this is something I wanted to give you understanding of the publications. So I presented something in a late breaking at the ACC. So this is, we are having something like a troponin without taking the blood now. So this is ECG in a tuxedo. So this was one of the ECG we get. So we never thought 10 years back that we will have a Paytm or a Google Pay, but we are using it. So mobile phones, your iWatches. So this was an WhatsApp message which came to me from my ICU, and I immediately, we had to go for a primary angioplasty. So it's so helpful. But what if you think that if you can gift somebody a tuxedo and you get in, so nowadays we are getting an ECG lead. I'm just going to play it from here. So we have, there's a team of people who are devising this. I don't know why it's not playing. Okay, this is how does it look. So this is basically a jacket which you can wear, which we have been using. It snugly attaches to the chest valve, available in all sizes, S, M, XL, and double XL. Male and female versions are different, and it has all the leads inside, and outside is the ECG thing which is stuck, and I can show you how you can wear it and what kind of data is available. So if you are sitting and you can wear a tuxedo like this person is, this is the device, it is Wi-Fi enabled, and the person can wear it and you get an ECG. So there are no leads, it is all Wi-Fi enabled. So just play it. So this was our presentation at the late breaking trial, which was presented at the ACC. And what is the background that this was a big study? You know what is the requirement of a high sensitive troponin, and the fastest you can get a troponin in your hospital is as early as 1 hour. It can be 2 hours, 3 hours, 4 hours. But the background was HS troponin is so important, and we needed something to develop this. So this was animal models which were first done on rats, where we occluded the coronaries, and then we had a post-op monitoring, and this was animal models of HS troponin. So what does it do is basically it's a watch with the person has to wear on his hand, and it's if you have seen your iWatch or Samsung watch, there are green signals which are there which are touching your skin. So it sends sampling and it receives sampling. So it is identifying some proteins, and this is how is the crude version 1, and we have the version 3.1 now, which is very small. It is already doing. So we tried to have an head-on comparison in all patients. So 250 patients of STEMI who came to our hospital, we took their sampling, blood sampling. Immediately the device was kept at the same time, and we got the report invasively report came in from a core lab, it took us almost 2 hours, but this device gave us report of troponin within 30 seconds. So there were 238 patients, and we had 5 sites. It was a multicentric prospective data. And so this is how the protocol works. So once the patient come, we just wipe the place. You see the timer, you put the hand on this and place it. It is absolutely safe, no pricks, nothing. The person straps it. 5 seconds, 4, 3, 2, 1, and the troponin value is, you send it to the data, it is 0.015 nanogram per ml. So you get the data within 30 seconds, that is what. So it is going to be a big screening tool, so a lot of validation studies was done, a lot of AI was involved, and this was the demographics of all these sites. These were all STEMI and non-STEMI patients, and this is the central lab data. So the important thing is we first had an internal validation and then external validation. The area under curve was 0.92, very high sensitivity and specificity, and accuracy came up to 98.3%. We also correlated with the phenotype sampling with the blockages in the coronaries, and the data was there. So the point is, this is going to be the future, and we had a simultaneous publication. So applications can be, it can be a good screening tool. We are not worried about whether the troponin is 602 or 608. If it is elevated, it is elevated. So it can be in emergency department, outcare, remote monitoring, a lot of things. And this has been published simultaneously in the European Heart Journal, and we are doing a big study to identify. So what I wanted to tell you that we are not way behind. The world is moving. Maybe next time in future, I don't know. So the only people who are very angry with me are the pathologists. They said that hamara kaam tum band karwa doge. So that's the thing. So thank you so much. So let me thank the whole West Bengal echo community, especially Deepankada, Dr. Rajat, Parmarth, for having me here. I mean, this is second home to me. I'm a Bengali, so I love being here. Thank you so much.